Hello everyone. As a part of continuous cardiac education, our topic of discussion today is 3D echocardiography and its clinical implications, which will be presented by Dr. Gajendra Dubey sir, who is professor in cardiology at UN Mehta Hospital, having 10 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
So, good morning. I am Dr. Gajendra Dubey. I am professor in cardiology at UN Mehta Institute of Research, Cardiology and Research Center, Ahmedabad. So, today I will be talking about 3D echocardiography. So, as we all know that echocardiography is one of the most important diagnostic tools used in cardiology. So, till date we have been familiar with 2D echocardiography, but recent advances, 3D is I can say a recent advance or a recent addition to our armamentarium in cardiac imaging. So why 3D echo is important? So it is very important to see the other side of picture, or I would like to say the complete picture. So as can be seen in these images, the image on left hand side shows you a nice sweet little girl and a robust looking man. But if we look at the other side of picture, the man is holding a bouquet and while the girl is holding a machete. So it is important to look at both the sides of picture to get the complete information. So here comes the role of 3D echocardiography. So 3D echocardiography, it tells us the structure of heart and its their relation to various surrounding structures. It is much easier to demonstrate to those who are echo challenged or not very well versed with echo. There is no need to rely on geometric assumptions when quantifying volumes, mass or function. So far the formulas or various functions which we use on 2D echocardiography for quantifying LV volume, EF, etc. They are based on several formulas which have certain assumptions which may not always be correct. So 3D echocardiography negates the need of those geometric assumptions and it gives us a more reliable and accurate results in for these values. It has potential of getting faster image acquisition and presentation of realistic view of heart valves, and plus we can also get more accurate volumetric evaluation of various regurgitant and shunt lesions. And apart from that, 3D stress imaging is also an evolving modality which can be useful in diagnosing myocardial ischemia. So what are the indications of 3D echocardiography? The first, as I told, that assessment of LV ejection fraction and volume, it is much more accurate and much more repeatable with 3D echocardiography as compared to two-dimensional echocardiography. Then assessment of mitral valve anatomy and MS mitral regurgitation, mitral stenosis assessment, this is much more accurate with 3D echo as compared to 2D echocardiography. Then during live guidance of transcatheter procedures like device closures or paravalvular leak closures or TAVI, it can be very helpful. And it is an excellent imaging modality for prosthetic heart valve evaluation. Then aortic valve evaluation, sizing of annulus, cusps and sending aorta pre-TAVI, it gives results which are almost at par with cardiac CT. And also it is helpful in evaluation of mass and volume of other cardiac chambers like RV or LA volume, and for dyssynchrony assessment for evaluation for cardiac resynchronization therapy. So this table shows the utility of 3D echocardiography in evaluation of mitral valve. With 3D echo you can exactly tell whether the prolapse of mitral leaflet involves the P1 segment, the P2, P3 or A1, A2, A3. This information is very vital for surgeons. So if they know beforehand what is the problem, then they can address it much more easily as compared to that evaluation by 2D echocardiography where this information may not be readily available. So its sensitivity and specificity is close to 100% for detection of abnormalities in different scallops of mitral valve. We can see the entire mitral valve apparatus very well with 3D echocardiography, as I'll show you later. So how does 3D echo is acquired? So the technology has evolved significantly over past several decades. Earlier the 3D echocardiography was not live acquisition. Multiple 2D images were acquired and they were subsequently post-processed to get a 3D image. But subsequently there have been transducers have been developed which can directly acquire 3D echocardiography. The initial transducers used to be quite big and they had lesser number of these piezoelectric elements. So the image resolution, spatial and temporal resolution wasn't so great and the probes were also quite bulky. But with evolution of technology, now we have probes which are as small as a 2D echocardiography probe, and they contain up to 2000 piezoelectric crystals. So imaging of entire volume of heart within a single heartbeat is possible with current generation transducers, and we nowadays we have a single transducer to acquire both 2D and 3D images. The frequency for transthoracic 3D probe is around 2 to 4 megahertz, while for that for TE is around 5 to 7 megahertz. So if we look at the acquisition mode, 2D echocardiography, it acquires multiple frames. So it is expressed as the frame rate or frames per second. While for 3D, it is the entire volume which is acquired. So its frequency is represented as volumes per second. So this is a flow chart for acquisition of 3D echocardiography. So first of all, you should get a good 2D image, because only a good 2D image can give you a good 3D image. Then you should select various modes. I'll just elaborate them. Then you should make finer gain adjustments and depth adjustment to get a good image. And then there should be this is followed by a final display, and then offline or online analysis with the help of cropping. So what are the various modes in 3D echocardiography? So it can be real time or live 3D imaging and multiple beat 3D imaging. In live 3D imaging is a relatively narrow sector acquisition. Then live 3D imaging can be done in zoomed view also to focus on a particular structure of interest. And then we can acquire the full volume set to get information on various aspects of LV function and RV function, or for cropping it later on. And we can also have a live 3D color Doppler to look or assess regurgitant or shunt lesions. Now, out of these acquisition modes, which one to choose for our particular examination? So it depends on what we want to look in that particular echo. So we have narrow angled or zoomed views. These are useful for assessment of valves like mitral valve or tricuspid valve or aortic valve, and assessment of interatrial septum and interventricular septum. Wide angle or multi-beat views are useful for assessment of ventricles, that is LV and RV, and for acquiring the whole image of whole heart and processing it later. So both single beat and multi-beat acquisition is possible with current generation devices. So what are the different advantages and disadvantages of a single beat acquisition and a multiple beat acquisition? The advantages with single beat acquisition are that it overcomes the limitation from rhythm disturbances and respiratory motion of the patient. The disadvantage is that the temporal resolution is not that great as compared to multi-beat acquisition. While the multi-beat acquisition, the advantage is that it gives you a higher temporal resolution image, while the disadvantage is that it can produce stitching artifacts, and it is susceptible to respiratory motion or cardiac arrhythmias. Then there comes another imaging modality with 3D image acquisition, that is the X-plane or multi-plane mode. So it is not exactly a 3D mode, but it gives you two views, in which one view is the one you acquire on 2D, and the second one is orthogonal to that particular view. So there is a dual screen to simultaneously display two real-time 2D images. One is the reference plane and the other one is the lateral plane. And the lateral plane can be 30 to 150 degrees from the reference plane. So this gives us the freedom or advantage of seeing two views from a single view. This is very useful in patients who don't have great echocardiographic windows, and it can give you images in multiple planes with a single view. So this is an example of the X-plane or multi-plane imaging view. Here on the left hand side we see the parasternal long axis view, and the simultaneous parasternal short axis view is seen on the X-plane imaging, and same is the example on the right hand side also. We can get this lateral plane or X-plane image depending upon where we put our cursor. So if we put the cursor at aortic valve, we will get the short axis of aortic valve. If we put the cursor at the ventricle level or at the tip of mitral valve, we will get the short axis of left ventricle. So it can also be used with color Doppler imaging also. So these are various examples where we can get short axis images from long axis views or long axis images from short axis views. So then comes the real time 3D mode. narrow sector. So it is a real-time display of 30 to 60 degrees of pyramidal volume. Narrow sector is generally insufficient to visualize the entirety of single structure in any one imaging plane, but it has a superior spatial and temporal resolution, and it is easy to use. It is mostly useful for valves and small structures. So these are few examples of real-time 3D narrow mode. So this can be useful for live guidance or focusing on single structures like mitral valve or aortic valve. Here we see the image of aortic valve. In the left hand side it is long axis view, and on the right hand side it is short axis view. Similarly, this is an example of real-time 3D image. It is showing the left atrial appendage. Then comes the 3D zoom view. This is the most, according to me, this is the most useful view of modality of 3D imaging, and it is very helpful in studying particular structures, most commonly the mitral valve. So here the window is focused to or the sector is focused to the area of interest, and it gives a wider sector view of that particular cardiac structure. It is very useful for valves and interatrial septum, but it has slightly decreased spatial and temporal resolution as compared to real-time 3D imaging because of wider sector width. It can be useful for cardiac intervention and best to visualize valves like mitral and aortic valve. So this is an example of 3D zoom image of mitral valve. Here on the left hand side we can see the mitral valve is from the LA aspect, that is the surgeon's view, with aortic valve placed at 12 o'clock, and the leaflet towards the aortic valve is the anterior mitral leaflet, and that opposite to it is the posterior mitral leaflet. And this is the same image of mitral valve, which is showing a small hole into the AML, which is leading to regurgitation. So here also are examples of 3D zoom imaging of mitral valve, which is showing thickened mitral leaflet with prolapse of mitral leaflets. These are further examples of the same 3D zoom imaging, and it shows us beautifully the particular structure of interest, that is the mitral valve here in this example. So these are various further examples of these 3D images. This is a prosthetic mitral valve, and we can see a lot of very clearly the prosthetic mitral valve ring and the structure of mitral valve. So continuing the 3D zoom mode, this is the 3D zoom view of interatrial septum. Here we can see the atrial septal defect in its entirety, and we can also assess the shape of atrial septal defect, which is not easily assessed in 2D echocardiography. Similarly, this is a case of mitral clip procedure. So it gives the 3D image echo gives a live guidance of procedure, and whether we have grasped the mitral valve leaflets correctly or not, that can be very well visualized in these 3D images. Now comes the full volume gated acquisition. It is the largest acquisition sector possible is used here, up to 100 by 100 degrees, and it gives good spatial resolution, and it has higher temporal resolution also, and it can be very useful for cropping and offline analysis, and it is used for assessment of LV and RV functions and volumes. So it is a multiple beat 3D acquisition giving us a higher temporal resolution, but it is prone to imaging artifacts which can be created by patient or respiratory motion or irregular cardiac rhythm. So we should instruct to the patient to hold his breath if possible during the acquisition of full volume images. Then comes the full volume image acquisition with color Doppler flow. So it utilizes 3D images plus color. Initially it was available only with full volume mode with 7 to 14 beats volume stitched together, but currently 3D color full volume can be acquired with as low as single beat, but the temporal resolution goes down, and it is useful for quantification of various regurgitant jets. We can get the vena contracta area and the regurgitant volume much more accurately as compared to 2D echocardiography. These are few examples of 3D color, 3D echocardiography with color. Here we can see in this image on right hand side that we can get the vena contracta area also, and it can be measured much more accurately as compared to 2D echocardiography. But the limitations are it has a relatively poor spatial and temporal resolution, and currently live 3D color Doppler acquisition is limited to small color Doppler volumes with limited temporal resolution, And multiple full volume acquisition of color Doppler, providing large Doppler volumes have several stitching artifacts, and they may not be that useful with current technology. But with evolution of technology, it may be possible to get good images in future with this view. These are further examples of color Doppler 3D echocardiography, which show regurgitant lesions across mitral valve. Now we come to the protocol for acquisition of 3D echo. First of all, I would talk about transthoracic 3D echo. So various protocols to assess various valves are almost similar to those with 2D echo. For aortic valve, a parasternal long axis view with and without color can be used. And similarly, for mitral valve, a parasternal long axis view or apical 4-chamber view can be used to acquire the image. For LV function, apical 4-chamber view is useful without apical foreshortening. For interatrial and interventricular septum also, the apical 4-chamber views are useful. For pulmonary valve, the parasternal right ventricular outflow tract view is the best view. And for tricuspid valve, it is again the apical 4-chamber view. So for 3D transesophageal echocardiography, for aortic valve, 60-degree mid-esophageal short axis view is the best view, or we can go to the 120 mid-esophageal view, which is almost similar to the parasternal long axis. Mitral valve can be imaged from 0 to 120-degree mid-esophageal views with or without color, and left ventricle again can be viewed in the 4-chamber view, that is between 0 to 120 degree. And the right ventricle also can be seen in the 4-chamber view. The interatrial septum is best visualized in 0 degree with probe rotated to the interatrial septum. And the pulmonary valve is seen with 90-degree high esophageal view with and without color. And tricuspid valve is again seen in 0 to 30-degree 4-chamber view. So these are various views which are to be utilized for acquisition of 3D images of structures of interest. Now, what are the various challenges with 3D acquisition? So there is a trade-off between temporal and spatial resolution, and the imaging volumes although can be adjusted to increase volume rate while maintaining the spatial resolution. ECG gating and breath hold play a very important role, especially with multi-beat acquisition. If these are not proper, there are cardiac arrhythmias like atrial fibrillation, or if the patient is not holding breath properly, we may get stitch artifacts which compromise the quality of image and its subsequent analysis. And finally, a suboptimal 2D image will result in a suboptimal 3D data set. So you should first get a good 2D image to get a good 3D image. There are various methods by which you can slightly optimize your 3D image. The gain should be optimized. It should be kept at around 50 to 60, and excessive gain or too little gain does not give you a good quality image. So it should be optimized before acquiring the image. So these are examples of overgain and undergain. Overgain will show a lot of blood artifacts. Undergain will show a lot of tissue dropouts, so both of which are not desirable. The stitch artifact, as I've earlier told, it can be due to a rhythm artifact or a respiratory artifact. And poor resolution, that is a compromise between volume and spatial resolution. So if you can decrease the sector size, you acquire focused images, then the resolution can be improved. So the beauty with 3D echocardiography is that once you have acquired the images, you can do a lot of offline analysis, and the images can be cropped from any angle, and that can give you a view of heart from any angle or whatsoever angle you want to see them. So it is inherent to 3D echocardiography. It is slightly different from tomography, and multiple cross-sectional views can be obtained with help of 3D echocardiography. It can be performed either during the procedure or later also, and that is available both online as well as offline. Softwares are there, and advantages of cropping are there during the procedure. If you are not getting the image of interest or you are not getting a proper image, you can do it again. If you are cropping during the procedure, post procedure you may not be able to do so. So there are various cropping methods, like with Philips system there is eye crop, where you can just focus on the area of interest and crop it and view it from any side you want, like top, bottom, front, behind, right or left. Then there is plane cropping, where you'll get both these three planes, that is the transverse plane, the sagittal plane and coronal plane, and you can crop the structure of interest from any side of your interest. So this is an example of multi-planar reconstruction which is available with 3D imaging. The radiology people are very well familiar with this, and it is very useful in CT scan and other tomographic imaging modalities. The advantage here is that you can get exact, like say if we are assessing the mitral valve area in a case of mitral stenosis. So most of the time with a 2D image we are not able to get a short axis exactly at the tip of mitral valves. But with this help of this multi-planar reconstruction, we get two long axis images in the upper two boxes. So one is the original image which is acquired. This is the 90-degree or reference image. So we have to centralize these two lines at the tip of mitral valves, and then here we get the short axis image where we can exactly measure the area of mitral valve at its tips, and this is the 3D volume, corresponding 3D volume. So post acquisition, the 3D images can be displayed with the help of either volume rendering or surface rendering or 2D tomographic slices. So the choice of display technique is generally determined by the clinical application, that is for the purpose for which it has been acquired. So volume rendering is basically a technique that uses different types of algorithm to preserve all 3D information and project it rather than processing it onto a 2D plane. So these can be electronically segmented and sectioned, and to obtain ideal cut planes, the 3D dataset can be manipulated, cropped and rotated and viewed from any plane or any angle desired. It provides the complex spatial relationship in a 3D display that is particularly useful for evaluating valves and adjacent anatomic structures. So this is an example of 3D volume rendering of the LV cavity. Here we can see the apical 4-chamber view focused on left ventricle, and these are volume rendered images which are useful in looking at the shape of LV and calculating its EF and volumes. So this is again an example of this volume rendering used for calculation of LV ejection fraction. The surface rendering is somewhat similar to volume rendering, but it gives us mostly these are mostly combined to get full details. So this is an example of surface rendering where the LV function is assessed with the help of this surface rendering. It gives you the global LV function, and also you can look at RWMA if you focus on a particular sector. These are further examples of volume and surface rendering useful for assessment of ventricular function. And this is a surface rendering of right ventricle. It gives us the exact shape of right ventricle and its contractility and EFs and volumes, which is almost comparable with cardiac MRI. And the other display modality is the 2D tomographic slices. So with the help of this, you can get as many slices or as many transverse sections you want in a particular image set. So these are 2D slices or cross-sectional transverse slices of LV at different levels. So with 2D image, we can get only a few cross sections like that at the level of mitral valve or that at the level of papillary muscle or apex. But with the help of this, we can get it at as many sections as we want, and we can more accurately assess RWMA or any anatomical abnormalities at any particular level. Now there is a convention, because 3D images can be cropped and rotated and viewed from multiple angles and side. So to bring uniformity into the 3D representation of various cardiac structures, the American Society of Echocardiography has recommended certain views for displaying a particular structure on 3D echocardiography. So left ventricle is conventionally displayed from in either the short axis view or the apical 4-chamber view, as can be seen in this figure. On top, on left hand side, it is the apical 4-chamber view displaying the LV, and on right hand side it is the short axis view displaying the LV and RV. The same applies for RV also. It is to be displayed in either apical 4-chamber view, as can be seen here, or in a short axis view with LA at 12 o'clock. Similarly, the interatrial septum, it can be viewed both from the LA side as well as the RA side. So when viewing from the LA side, the atrial septum should be oriented with right upper pulmonary vein at 1 o'clock, and when displayed from the RA side, the SVC should be at 11 o'clock. So these are the corresponding views and this is the right upper pulmonary vein at around 1 o'clock. This is the atrial septum, this is LA appendage, and this is aorta. And if we look at it from the RA side, then this is SVC, this is aorta, this is the right upper pulmonary vein, and this is the interatrial septum. The left atrial appendage is to be displayed en face with pulmonary veins at around 1 o'clock. Then mitral valve is to be displayed en face from the LA aspect or LV aspect with aortic valve located at the 12 o'clock or at the top. This is known as surgeon's view, and once it is located like this, then atrial appendage, LA appendage will be there at around say 10 to 11 o'clock, and this leaflet which is facing the aortic valve is the anterior mitral leaflet, and that opposite to it is the posterior mitral leaflet. So it is to be displayed with same orientation if we view it from either LA side or the LV side, which is on the right hand side. The tricuspid valve is displayed with interatrial septum at 6 o'clock or posteriorly, and it can also be visualized both from the RA side as well as the RV side, but IAS should be located at 6 o'clock. Aortic valve is displayed with RCC pointing down, that is towards 6 o'clock, and the pulmonary valve should be displayed with anterior cusp at 12 o'clock position. So these are standard display views so that there can be uniformity in reporting and imaging. So what is the utility or advantage of 3D echocardiography over 2D echocardiography? So there are various studies have been done which have shown that assessment of LV end diastolic and systolic volumes, LV mass, LA volume or RV end diastolic volume, they correlate very closely with cardiac MR if we are using 3D echocardiography. That is not the case with 2D echocardiography because there are several geometric assumptions which may not apply in all cases. So here we can see that 3D echo is almost as good as cardiac MR in assessing these functions. And the detail of mitral valve which we can get with 3D echocardiography is unmatched. It cannot be seen with 2D echocardiography. So this table again shows the comparative accuracy of 2D and 3D TT and TE in identifying mitral valve pathology in patients undergoing MV repair. So these modalities are reliable for functional MR and they are comparable for diagnosis, but mechanism of MR can be better appreciated with 3D echocardiography. So now I'll show you some case examples, some 3D images which I have acquired and I found them to be useful, and they have provided me information which was more than what I got from a 2D echo. So this is an example of prosthetic valve endocarditis, and on the 2D image we can see that there is mitral regurgitation, paravalvular mitral regurgitation and some movement of the prosthetic valve leaflet, but this is a corresponding 3D TE image of the same mitral valve from LA aspect. Here we can very clearly see that there is prosthetic valve dehiscence extending from say 6 o'clock to 11 o'clock, and there is a large paravalvular crescentric defect through which there is mitral regurgitation. So this detail was not at all visible in 2D echocardiography, and it can be very well seen here. So this is the large defect, and we can see some small vegetations also which are attached to prosthetic mitral valve. Then this is another case of prosthetic mitral valve thrombosis. In this example, we can see that one leaflet on 2D TE imaging, we can see that one leaflet is mobile while the other leaflet is stuck. The corresponding 3D image from left atrial aspect, it very beautifully demonstrates the prosthetic valve ring which is normal, there is no dehiscence, and this is the one leaflet which is mobile, and this is the other leaflet which is stuck in closed position, and we can see some thrombus also on the left atrial aspect. Then this is another case of a prosthetic valve thrombosis. This is the previous one was a St. Jude bileaflet valve. This is TTK Chitra single leaflet tilting disc valve. So valve has almost opened up, but in this 3D echo image we can see that there are small filaments of clot which are attached to the prosthetic heart valve. This case was thrombolized. These images were required after thrombolysis. So the leaflet movement has almost normalized. Here we can very well see the orifice, the central orifice of this TTK Chitra valve and the major orifice as well as the minor orifice of the TTK Chitra valve. So this is another case of prosthetic heart valve thrombosis. Here the culprit valve is the aortic valve. On the 2D image, nothing much is visualized. The valve leaflet movement can be seen to an extent, but on this 3D image, we can very clearly see that there is a dangling thrombus involving the aortic valve, and which is leading to restriction of valve movement. Then we have another example of prosthetic heart valve. Here we can see a lot of pannus, that is this structure, fibrous type of structure present above the valve ring, and there is a paravalvular defect also somewhere at around 2 o'clock, and which was confirmed with color imaging. So here we can see that there is a lot of turbulence and there is paravalvular leak. So this was a case of prosthetic aortic valve with pannus and paravalvular leak. Then this was a plain or routine rheumatic heart disease with mitral stenosis. So we have both the LA aspect as well as the LV aspect of mitral valve. So this is the LA aspect. Here we can see the mitral valve is thickened, and there is this big chunk of calcification which can be seen attached to the posteromedial commissure of near posteromedial commissure of mitral valve, and this is the mobility or opening is restricted, and this is the corresponding LV aspect, which shows us the typical fish mouth appearance of this rheumatic mitral valve. This was a very good and rare example of a mitral blood cyst, and so this is a cystic structure which is attached to mitral valve. It can be seen on 2D transesophageal echo also, and there is moderate to severe mitral regurgitation also, and the corresponding 3D image exactly tells us the site of attachment of mitral cyst, which is near the posteromedial commissure, and we can clearly see that this mitral cyst is interfering with complete closure of mitral valve, and hence it is giving rise to mitral regurgitation. And these are last few examples are those of the septal defects. The first one on the top is an atrial septal defect, although it was the size was coming around 22-23 on 2D echocardiography, but on 3D we found that it is a oval shaped structure, and the largest dimension was quite large, close to 40 mm. So this patient was sent for surgery. Then this other two images are, this is a small ESD, the image on left hand side, and here we can see all margins are quite adequate, and this patient underwent device closure. And this image in the lower panel on right hand side is that of a ventricular septal rupture post MI. So here we can very well see in this NFAS view the shape of ventricular septal defect, and this patient was also sent for surgery. So these were few examples, real life examples of 3D imaging and its benefits as compared to 2D echocardiographic imaging. So thank you all for your attention.